on the system. So the recording is on.
Sure.
So guys, welcome to the Thoracic Gurus lecture series. It's indeed an honor and a privilege for me to introduce to you our speaker from today. He's a very, very close friend of mine, Dr. Abdul Gafoor Mubarak, who's a consultant general and thoracic surgeon in Langkawi General Hospital, Malaysia. He is, I believe, soon to be moving to Penang in Malaysia. And I was very fortunate enough to meet him a couple of weeks ago when he hosted us in Kuala Lumpur during the Asian Thoracoscopic, the ELSA, the Endoscopic and Laparoscopic Society meeting. He has got great experience with dealing with empyema thoracis. The common thing that you'll find is in Malaysia, the patients are more or less the same. The disease pattern is more or less the same. So everything that he talks about will actually help us in our clinical practice today. So
Great.
Dr. Gafoor, the floor is all yours.
Thank you.
The format of the talk is going to be, you are going to be talking for the first whatever time you want. There is no time limit. And then we will ask each one of them to switch on their microphones and then they can ask questions. And this is supposed to be an exam going session. So I really want you to focus on individual, small points which they can be asked in the exam.
Sure, definitely.
Dr. Gafoor, please take over. Thanks.
Thank you.
At some point during the presentation, I may have to log off because I've got a case going on in theater, but I'll try as long as I can. Thanks.
That's fine. So, okay, guys, good evening, everyone. And I'm sorry for the hour is a bit early, I believe, for you guys. You'll be completing cases in the theater and things like that. And the reason is because there is a time difference of about 3 hours between Malaysia and India. And it's a bit difficult for me to do it at 10:30 at night. It will be about 1:30 in the morning on my side. And it will be a bit difficult. So let me start off by introducing myself. My name is Abdul Gafoor Mubarak. You can call me Gafoor. Most of my friends call me G. And I basically am a good friend of Dr. Zamir, whom I met about 2 years ago. And I developed a keen interest in thoracic surgery after attending one of his courses. And I have currently been a consultant at Langkawi General Hospital, and I'm scheduled to head the General Surgical Department in Penang in about a couple of months' time. Okay, just to give you a brief description of Langkawi, you can see the two pictures below over there. That's basically where I stay. It's very nice. It's full of white sandy beaches, and the scenery is very nice, and it's very good for people to come to have holidays. We have about 4 million tourists coming to Langkawi every year. And all of you are invited after your exams. And when you pass, it becomes much better, basically. Okay. So the outline would be basically.
Dr. Gafoor,
I thought it would be a bit. I thought it would be a bit misappropriate to show that, actually.
All right, sir. Okay, thank you. Sorry for the interruption, but I couldn't resist myself.
But I can arrange that for a private session with you, Dr. Zamir. Don't worry.
Thank you, sir.
Right. So
carry on, Dr. Gafoor.
This presentation would be basically based on the BTS criteria and what we are doing in Malaysia. British Thoracic Society, I think, would be the easiest criteria for you to use for exam going purposes. The reason is because most of you are going for FRCS based exams, and even the local exams in India also would be to some extent the FRCS format. And so I believe I stuck closely to the BTS criteria. So you have stages of empyema, complications, management, indications for surgery and approaches. This is only a brief outline, but we will get into what is more intricate stage by stage. So for your exam outline, for these purposes, for this purpose, I believe you should know some MCQs with regards to empyema thoracis, short and long essays, short case and OSCE cases and long cases. Now, for thoracic surgery, I believe one of the most challenging aspects would be the MCQs, because the intricate knowledge that you have to know on disease pattern is very specific, and most of the time they can ask you very particular or very precise questions that you need to know. So on the MCQ side, I believe a broad base knowledge would be beneficial, and I can't deliver it all in this talk. For short and long essays, for Empyema thoracis per se, you might be asked regarding new criteria, especially with regards to the new BTS criteria, British Thoracic Society criteria, and also you might be asked with relation to any new management criteria, especially in relation to diagnostics that have come up. A short case in regards to thoracic surgery will definitely be there, because it's not difficult for them to find a patient with an open window or a patient that has had surgery for empyema thoracis with the chest drain. So this is what you call a slam dunk case, you know. If you have an empyema thoracis patient for an exam, it is one of those cases where you have to stand up, you know, pull up your collar and thank God that you had this case, because it's quite straightforward. For a long case, I believe in empyema thoracis, usually you will be given a case that has had some complication related to the empyema itself. That means maybe the patient would have undergone a primary surgery and there might be a complication of fistulation that might have occurred along the way, and a second surgery would have been indicated. And this would make it more interesting for a long case presentation. So all in all, focusing on empyema thoracis, for the exam purposes, most of the time you will get straightforward cases. But mind you, if you get those cases, you have to know everything about it, because it is such a common disease in our part of the world, Malaysia, India, and other developing countries, that the level of expectation, especially in knowledge, should be very high. Okay, so now let's move on to some exam fears. I'm sure many of you are very familiar with the exam format. But I believe in FRCS and especially MS exams that you are pursuing, you have to know what you are afraid of. The examiner is always this angry person that you see shouting at you during the exams or before the exams. I'm sure Dr. Zamir is not someone like that, and I'm pretty sure. And the patient is someone who's very expectant and very sad looking. But I think among these three, the element that you should be most careful about is the element of time, especially when you're going for a postgraduate exam. You are basically fighting for time, and basically you have to prove to the examiners in the very short amount of time that you have that you deserve to sit on the other side of the table as a consultant or a specialist. So please the only way that you can master this element of time is by practicing, talking, preparing cases, practicing with your colleagues and things like that. Okay, so let's go with a few MCQs. Since I can't hear you, maybe you guys can put a thumbs up for yes and a thumbs down for no. Will that be okay? Okay, thumbs up for yes. All right, great. Okay, so the first one, true or false? Normal pH of pleural fluid is around 7.6. Okay, so we have one thumbs up.
Gafoor, if they want to answer, they can switch their microphone on.
Please switch your microphone on, and maybe we can switch it on.
We've got a lot of people on, so if they want, they can switch their microphone on. Yeah, I'll try to moderate so that I get the. So whoever wants to answer, please, raise your thumb on the system. You know how to do that, isn't it?
So Dr. Amol, can you answer, please?
Sir, it's around 7.4.
So okay, 7.2. That's good. But you would be surprised, Dr. Amol, that there are several textbooks that give you a range, and this range is from 7.4, and some textbooks go up to 7.4 to 7.5. But I think for our purposes, if you use 7.4, that would be quite good. Okay. Second question, true or false? Normal human volume of pleural fluid is only 1 millimeter.
Yes, sir. True. Less than 1.
Yeah, that is true. Yeah, that's great. So
Amol, give everybody a chance, man.
Yes,
so that's good. Okay, LDH is among the smaller molecules found in pleural fluid.
Who wants to take this? This is a superb question. It's okay to be wrong.
No problem. If you get it right, there's no issue. You get it wrong, there's also no issue.
Andre, do you want to take it?
Andre.
Yes, LDH normally, yes, I think it's true.
It's true. Okay, part of the statement is true, but part of it is wrong. So LDH is found in pleural fluid, but it is not among the smaller molecules. It is among the larger molecules found in pleural fluid. The smaller molecules would be macrophages, your blastocytes, and those types. So this would be something that you should be careful about. Okay. Majority of patients with pleural infections have an inherent risk factor. Dr. Mithun, are you there?
Yeah, Mithun, come on. Mithun, you can come on.
Hello, sir.
Yeah, hi, Mithun. Hi.
Sir, I think it's true, sir. There must be some inherent risk factors for patients.
Right. So this would be, you're actually right, Mithun, but by statistics, majority of patients with pleural infections do not have any inherent risk factors actually. They come with totally being fine and they develop pleural infections. All right. So statistics are always very commonly asked during exams. So 5% of patients with Empyema thoracis die in the UK. That means in general. Dr. Amol, again, would you like to try this?
Sir, I don't know, but I can guess, sir. I think,
yeah, please.
mortality is more than 5%. It's not 5.
You think 5% is too low?
Yes, I think so.
You think 5% is too low? Dr. Andrea, what do you think? 5% is too low?
It's lesser than that.
Lesser than that. Actually, you would be surprised. Across the board, 15 to 20% of patients die of Empyema thoracis actually in the UK. Numbers are quite high. All right. Okay. So that's the first MCQ. So, I mean, MCQs are something that, are designed to test your intricate or your minute knowledge. So it's okay if you get it right or wrong here and there. Okay, so to start it off, empyema is basically an accumulation of pus within the pleural cavity, which may be localized or it may involve the entire pleural space. So as you might be aware, you have got two linings, a visceral pleura and a parietal pleura. And what happens in between in this space is what is considered the pathology that we are discussing. Okay, this is the slide that most of you are familiar with, in which there are three phases of Empyema thoracis: an exudative phase, a fibrinopurulent stage, and a chronic organization stage. Okay. Now, what you have to be aware about is there are a few caveats to this statement. Number one, these stages do not occur according to the time, 2 to 5 days, 5 to 10 days, 4 to 6 weeks. There is often an overlap, and there is often a jump between the stages. An exudative phase can be a very short phase, but a fibrinopurulent phase can be a longer phase, and it can sometimes even jump from the first phase to the third phase occasionally. All right. What you have to be aware is, I'm sure many of you know that a chest tube drainage would be indicative in an exudative phase is stage 1, and stage 2 and stage 3 normally a surgical approach would be indicated. But what is the reason behind this? The reason behind this is, in an exudative phase, you have to understand that Empyema thoracis is not a static disease. It is a dynamic disease. There is movement of pus in the pleural cavity. And this exudative phase still maintains that dynamic movement where there is a movement of fluid in that space. A fibrinopurulent phase basically is a phase where most of this movement comes to a halt. And if you apply a drainage at this point, your yield may not be very good. You can get some, but your yield may not be very good, and you may or may not be successful. A chronic organization phase is a phase when most of it forms a layer around the lung, and this is when the instances of a trapped lung become more apparent, and a surgical intervention, whether it's thoracoscopic, whether it's open through a thoracotomy, would be more indicative. But the take-home message here is, at face value, the timing that is given in most textbooks and is given in more literature, 2 to 5, 5 to 10, and 4 to 6 weeks, in reality, they do not occur so well. And this becomes important in day-to-day practice, because when we are referred a patient, we tend to backtrack as to when the symptoms began, and we tend to speculate as to at what stage the Empyema thoracis is. So in this particular slide, I think I would like to just take some time and ask if any one of you have any questions on this one, because I think this would be the more important segment of the presentation? If not, I'll just carry on. Is that okay?
Yeah.
Okay, great. So carrying on, another MCQ, huh? Okay. I think you all should have taken some time to ask me something in the previous one. So the MCQ wouldn't have come up.
Absolutely.
The following are features of a fibrinofurulant fluid. Number one, let's try Dr. Amol, pH of more than 7.2.
No, sir, it will be less than 7.
Excellent, good. pH of less than 7.2. Are there any instances when a pH can be more than 7.2, Dr. Amol, you think?
More than 7.2, but it is that you mean.
Sorry?
You are just generally asking more than 7.2 or?
Yeah. What are there any instances
Sir,
when the pH of the pleural fluid is more than 7.2 and it is a fibrinopurulent fluid?
sorry, when it is associated with chylothorax, it is more than 7.4, but it can be.
Right. So you do have some organisms, especially urease splitting organisms like protease, that actually produce a pH of more than 7.6 at times. So this would be something that you should be careful about in your MCQs if they were to ask you. All right. Dr. Andre, a glucose of less than 2.2?
For an exudate.
All right. So that means this will be a fibrinopurulent fluid if it is less than 2.2?
Yes.
Okay. Dr. Amol, do you agree?
Sir, it is less than 3.4 millimole per liter.
Yeah. So higher than 2.2 would be the correct answer in this case. Obviously, a frank pass would be indicative. What about an LDH of more than 50,000? Dr. Vikas, are you there with us? Hi, Dr. Vikas, are you there? Hi. Oh, it's okay. Dr. Andrea again, can you LDH of more than 50,000? Would it be features of a fibrinopurulent fluid for MCQ purposes?
I came across an exudate and aspirate. Not sure about this.
So the figure that you must remember is 100,000, not 50, eh? Okay. Okay, so all right. What if you don't obtain any fluid on your aspirate? Will that be indicative that there could be a fibrinopurulent fluid and you're not able to take it out?
Yes, sir, because we might not enter the correct location.
Yes, you're right. So most likely it has gone through a second stage and is going through a third stage now. Okay? Is everybody okay with this? Great. Let's move on. Huh? Okay. Okay, so this is a diagrammatic representation of how do you treat patients with pleural infection. I took it off the new BTS guidelines. I want you to start your focus at this area here where it says pus. Okay, so it's very easy to manage the patient when you have pus, because when it is present, then the management would be to insert a chest tube, and subsequently you have to monitor the patient whether the patient becomes better. And as the sepsis improved after day 5 or day 7, you can decide to remove the tube, or if the patient does not and deteriorates, you might decide to proceed for surgery in this case. If the patient is fit enough, you can subject the patient to radical surgery, which is basically a thoracotomy or a VATS drainage. If the patient is not fit enough, you can consider even an open window, or you can increase the caliber of your chest tube drainage. The problem occurs.
Dr. Gafoor, we can't see your marker.
Oh, I'm sorry.
Can you bring your mouse up and show us what you were talking about?
Sure. I thought I pointed it here.
We can't see your mouse for some reason. Hello?
Yeah, I'm here. I'm just trying to get the mouse up, sir. Sorry.
No, that's all right. It's just it will show us where you're pointing to, because this is a complex graph. So we want to make sure we know exactly what point we're talking.
Just give me a while. Just give me 1 minute. I'll just get it out. Just give me a minute.
it's okay. I'll point out. You carry on. You say it. But I'm not sharing my desktop, but I'm hoping that you can see something. Dr. Gafoor, that's all right. Just carry on. Dr. Gafoor, just carry on. Don't worry.
Yeah, I'm sorry.
Yeah, just carry on. Just carry on. Don't worry. So it is the fourth line that he was talking about, the pus.
Yes, the fourth line.
Yeah.
So maybe I'll just carry on because I can't seem to get the mouse on board.
That's okay. Carry on.
Okay. So if the issue occurs when you don't have frank pus, all right. So in this case, then what happens is you have fluid which you have to decide whether or not you need to proceed for surgical or non-surgical intervention. So you send your fluid for pH, for culture and sensitivity, for gram stain, and you establish whether the pH of the fluid is less than 2.2. If the pH is less than 7.2, so not 2.2 is 7.2, and the culture is positive, you can proceed for a chest tube insertion in these patients. However, if you find that there is no evidence of gram stain, or the pH is not less than 7.2, you can observe the patient unless the patient deteriorates clinically and requires a chest tube drainage. And you can also perform a repeated fluid sampling to determine if you need to do other modalities of treatment for these patients. What I want to indicate is, in this complex diagram, job becomes very easy when you have pus basically, and it becomes more difficult when you don't have it. So as compared to other areas of surgery where you don't like seeing pus, in this area basically it's much easier when you see pus, and then you can manage the patient quite easily. Okay, right. So let me just get this out. So on chest X-ray, you basically have classic features of lenticular opacities in the pleural cavity, blunting of the costophrenic angles, and you can have dense linear shadows layering between the lung and the chest walls. And usually in stage 3, in number 3 of these features, you can find that this empyema thoracis is quite bad. I have some examples here. These are my own patients. So you can see that there is a lenticular concavity on the chest X-ray. And in figure number 3, you can see that there is increased shadowing to indicate that these patients have empyema thoracis. Obviously, if you have someone like this, you wouldn't waste your time doing many things. You take him into surgery quickly, and you optimize him before that, and subsequently, the relevant imaging modalities would be required. This patient, interestingly, was actually a young man who came from the remote areas in Malaysia, also by helicopter. And he's been having this, strangely enough, for about 4 months. And a few doctors had actually visited that remote area, and they did not send him to us. But there was a local doctor, we call him a BOMO here. He is a traditional doctor, one of those witch doctors. And he diagnosed him with something in the thoracic cavity and referred him to us, and we managed to do the procedure. So sometimes the referrals from the witch doctors are better than our local guys at times. So, okay. So when we performed the CT scan, we found that he had a very organized collection, Dr. Zamir, as we can see here.
Yeah,
and it was very, the lungs relatively were quite okay. And the procedure was quite straightforward.
It's the most amazing CT scan I've ever seen.
Yeah, it's
just amazing.
And he was quite well, and he tolerated the procedure quite easily. So now, when do you need a CT scan? Now, I would say in this day and in this age, definitely a CT scan would be helpful. when you are considering thoracoscopic surgery, when you are considering the disease itself, I would think that a CT scan gives you a host of information that is important. But basically, to diagnose the condition, you should memorize these three features: thickened contrast enhanced pleural rings, loculated septated lenticular high density effusions, and a split pleural sign caused by pleural enhancement and fluid separating the parietal and visceral pleura. Is there any role for an MRI, you think, in a patient with empyema thoracis? Dr. Amol, would you think that there is an indication for a need for an MRI?
Sir, as long as we don't have a diagnostic dilemma, I don't think any.
Sorry, a patient presenting with?
Sir, if there is a diagnostic dilemma between.
A diagnostic dilemma, is it?
Yes.
Yeah, but strangely enough, a CT scan is actually quite a good modality for you to pick out even the smaller empyema thoracices. There is an indication. Number one, I would think that you will need an MRI if the patient has got some renal failure and there is an element where you cannot give the patient contrast medium. And so an MRI comes into play in these cases. The second is when you have those weird empyema thoracices, empyema necessitans, or your mycobacterium empyemas. These are atypical ones that are difficult to diagnose by CT, so an MRI would be helpful. But generally, you can get away with a CT scan, which is a sole modality, in about 99% of the time. Okay? So this would be the split.
Dr. Gafoor, the one place where an MRI would help would be in a pregnant young lady.
Definitely.
Empyema. So that's
So this
would be a CT. So
agreed, sir.
that
Totally
would be an MRI.
So in any case where you basically do not, are not able to do a CT scan, basically, either due to contrast or radiation and things like that, and also your atypical cases. So this would be your split pleural sign indicated by the arrows. It is as if the pleural space has been split, and it is basically a false perception, but you can see it on the CT scan quite clearly. And these are the group of scans that I have to show this particular sign. You can see it quite clearly in the second and third picture below. Okay. So what are the common organisms that you get? So most commonly, you can divide it, because most of your patients will come because of community-acquired pneumonia that complicates into empyema thoracis. So you have community-acquired and hospital-acquired. For community-acquired, you have got Streptococcus species amounting to half of it. And please memorize these figures, because I'm very sure that they will ask you this in the MCQs. Staphylococcus and gram-negative aerobes. For hospital-acquired, your MRSA strain, strangely enough, accounts for 25% of these patients. And Staphylococcus aureus amounts to 10%. Gram-negative aerobes are 17%, which includes your E. coli, Pseudomonas, Klebsiella, and your anaerobes amount for 8%. If you happen to have a fungal infection and from your fluid, then the patient is very unfortunate, because the prognosis in these patients are usually very poor. So now let's get down to the gist of it. Management of these patients. Basically, you have to understand that the management consists of a multimodal approach, and it is not only the thoracic surgeon who is the hero in this case. The team that is around it basically are all called for. Nutrition is a very important element in these patients. Many of them are hypoalbuminemic, and you need to have a very good dietitian to manage them pre-operatively and post-operatively, because it affects the outcome of the patient. Your team members have to be identified. You need a respiratory physician on board, or a physician that has got some respiratory interest. That'll be the best. Aggressive physiotherapy or using Dr. Ali Zamir's yoga techniques would be perfect as well. I kind of learned a lot of those techniques after I came back from my class with him from India, and it has helped my patients tremendously. Thank you, sir. Right. Optimize the comorbidities in these patients, get a physician on board. Thrombosis prophylaxis is one that many of us neglect in these patients. You have to understand that patients with empyema thoracis pose a high risk for thromboembolism, and many of them require actually a low molecular weight heparin prophylaxis. And if you are unable to provide them for some reason, such as renal failure, heparin subcutaneous, it should be administered. And I routinely do this for my patients actually when I do the Milakawi. Now, antibiotics, most of them will be culture negative, but you should extend it for 4 to 6 weeks from the time that you start it. So what happens when you are referred a new patient for pneumonia? Usually, when you have a new patient for pneumonia, sometimes you come across these cases, especially in private practice. You give them 2 to 3 days to have a resolved temperature, heart rate, and oxygen saturation when they come in for acute pneumonia. After which, you must suspect that these patients have got some sort of parapneumonia sepsis going on. You can use CRPs to predict that these patients can lead to an empyema or a parapneumonia sepsis. CRP is not readily available in most centers. I find the predictive scores to be not very helpful, but for exam purposes, you should have predictive scores where an albumin less than 30, CRP more than 100, a platelet count more than 400, a sodium less than 130. If the patient is an intravenous drug abuser or a chronic alcohol abuser, you have to be aware that these are risk factors that can lead your patients with pneumonia into a parapneumonic sepsis and also to an empyema thoracis later. Okay, what are the indications of pleural fluid aspiration? If you have pleural effusion with sepsis or pneumonia, then you should obtain a pleural fluid for culture sensitivity. If you suspect that there is more than 10 millimeter thickness of effusion, you should suspect. If it is less than 10 millimeters, you can observe. When you take the fluid, you have to subject the fluid to at least pH and glucose. And as you already know, pH of 7.2 and below would be indicative of an infection, and a high glucose level will also be indicative of an infection. And I've already explained pH of 7.6 in some diseases, such as protease, can also be an indication for patients with leading to empyema thoracis. So far, everybody's okay? You're good? Everybody's good? Okay, good. Okay. Let's go to the more interesting ones, the ones that we like.
Yeah, it's going very well, Gafoor. Really enjoyable. Very well.
So, indications for chest drainage. Now that you know what to do with the fluid that you drain, when do you decide to put in a chest drain? Of course, if you have an empyema from pus, great, put in a chest drain. If you know that there is a loculated pleural collection, this is a subject of contention, because if the patient is asymptomatic and if the patient is well, and yet you know that there is a loculated pleural contention, would you or would you not put in a chest tube? That would depend entirely to the practice that you have in your setting, basically. And patients has got a poor clinical prognosis with antibiotic alone, which I've explained before. You give the patient 2 to 3 days. Right. Based on the new BTS, revised BTS criteria, you have got a few other indications. If you isolate gram stain or culture from non-purulent fluid sample, you should drain these patients with a chest tube. If the pH of your aspirate is less than 7.2 with suspected pleural infection, there is a class B evidence that indicates that you need chest tube drainage. If you don't have any of these indications, you can manage these patients with antibiotics, and you can observe the patients by clinical progress alone. If the patients for some reason have got poor clinical prognosis with antibiotics, again, a chest tube drainage would be indicated as well, level B evidence. Patients with loculated pleural collection should receive early chest tube drainage, but this evidence is more of class C, and large non-purulent effusion should be drained by aspiration and or chest tube if required, and as per symptoms benefit. So basically, if you have a positive gram stain, if the pH is less than 7.2 on aspirate, then a chest tube drainage would be indicated in these. If not, you can manage these patients with antibiotics and observation alone. Loculations are a sign, are area of contention whether you can or you cannot do. And large fluids which are non-purulent can either be drained by aspiration using a pigtail catheter or by chest tube drainage. Okay, all right. So when you put in a chest tube, what chest tube do you put in? Now, when I began inserting it about 6-7 years ago as a specialist, the term was the bigger the better. So in some cases it's true lah, we have to agree lah, but not for chest tube lah. Yeah. So for chest tubes, for chest tube. Sorry, Dr. Samir. This is the bikini talking in Lanka after being in Langkawi for so many years. so we used to insert very big chest tubes. I remember when I used to insert even chest tubes at 20 plus French, and my consultants used to come and shout at me, and I used to feel so stupid at the time. But now the thinking is different. The thinking is you can put in smaller tubes, 10 to 14 French, but the priority should be given to guided, flexible wound drainage, which basically give you more freedom to increase the size when needed later. Understood? Okay. So image guided pigtail catheter drainage is also possible, and the goal is apposition of pleural spaces. When you use this, do you apply them to suction devices? Well, you can, and there is no evidence to say that if you do, it helps, and there is no evidence to say that when you don't, it doesn't help. But if you have a Medela device, please use it, and if you have other smart suction devices, please use it as well. What about patients that have got obliterated pleural spaces? In these patients, usually surgery would be the best options. And if you have a multiloculated empyema, chest drain and a pigtail drainage would have very limited application unless the patient is not fit to undergo more radical or more advanced procedures. Okay, so we understand that the tube doesn't require to be big. It requires basically the newer guidelines advocate smaller tubes. Emphasis should be more on guidance, should be more on flexibility of the tube for comfort of patients, and it should be small. And we established that you may or may not use a suction device, it does not matter. And if you have multiloculated empyema or obliterated pleural spaces, your chest tube drainage may not be helpful. Okay, when do you proceed to surgery? Now, if you have residual effusion on the X-ray at day 5, I don't take day 7, I take day 5 in cases, but for your exam purposes, day 5 to day 7, and you should answer day 6. 6 seems to be a good answer in most exams. Every time you answer 6, usually is right. So day 6, usually it's okay. Non-re-expansion of lung after the evacuation, multiple loculated, chronic empyema with trapped lung, and presence of complications, such as patients having worsening sepsis. So, the American Association of Thoracic Surgery consensus says that intrapleural fibrinolytic should not be used routinely for complicated pleural effusions. In fact, now we do not, yes.
Dr. Gafoor, I just need to scrub in, so I'm going to just keep the thing running, but I will not be at this end. I'm so sorry about this.
Sure. Thank you, Dr. Zami. No problem. I'll manage it. No problem. Thank you, sir.
Please, thanks.
Thank you. Take care. Bye-bye. Have a good surgery. Okay, guys. So fibrinolytic therapy, guys, look here, is one that we don't use anymore. And they love to ask you this in exam because most of the examiners are, from the 1970s, 1980s, 1990s era that used a lot of these fibrinolytic therapies at that time. Fibrinolytics with and urokinase began in 1949. So you can imagine in the 1990s and early 2000, it was at the height of its usage. And we used it very routinely for patients with empyema thoracis until we discovered all the complications. So now the recommendation is do not use any of them, even the newer therapy. And if you have a patient with empyema thoracis, class 2A evidence says that a VATS approach should be the first line approach in patients with acute empyema. Anybody okay with that? Good? Great. Okay. This is what I normally ask my residents in the exam, and usually they don't get it right. So this is the one that I want to focus on. Okay. So you know now that stage 1 would be an indication for you to have a chest tube drainage. Why? What do you take the fluid for, and what do you do with it? Now, what about stage 2 and stage 3? Well, the only options amenable to you would be thoracotomy, either open or VATS. Your VATS approach can be single port, double port, triple port, quadruple port, 5 ports, whatever port that you want to insert, as long as you call it VATS, it should be okay. The idea is to break loculations and peel off thick fibrous cortexes. And you can understand, you should know that if the symptoms last for more than 4 weeks, it usually predicts a poorer outcome. Patients that have got poor preoperative preparations, as well as patients that are not fit for thoracotomy or VATS can be subjected to an open pleural window with rib resections. Okay, so this is a case that I did quite recently, which is about a week ago, and you can see the very thick peel on the lung. And in this case, I did, unfortunately, the lung was actually destroyed after the dissection. And this is the thick peel that I got on a very recent case, as recent as 5 days ago. So I'll just show you a quick video. Is okay? Right. So as you know, when you get into the cavity, your biggest challenge is going to be space. So I do not know why for the past 15 years nobody has actually settled this problem. That they should find a device that actually can help you create more space in the thoracic cavity. This is the most important step. Pick up a peel with a non-traumatic forceps, lift it up and use a peanut to go in between the two layers and subsequently peel it off gradually. That's the most, once you've come to this, basically everything else becomes very easy. So the more difficult aspects of surgery would be the lateral aspect, in which when you retract and when you reach the lateral part, the peel becomes more thick, as you can see here, right? So it becomes a bit more difficult for you to differentiate the peel from lung. So you have to be a bit more careful when you come here. So when you come, a better camera placement would be ideal at this time. So basically, you work your way gradually, layer by layer, and usually you should be able to finish the procedure. And subsequently, after that, you do a water test to determine whether you have any leaks. And then you can use a guided chest tube and you can insert it. And usually you're done after that. All right, understood? Okay, great. So let's move on to the other one. So you can do a pleural window. Patients that are unstable for open surgery, patients that you think would benefit from this, you can. It's a very simple procedure. You do a skin flap and then you suture the skin flap to the parietal pleura using your conventional sutures. And this is a recent case which I did about a month ago. Patient did very well, and I sent him back to his hospital very recently. Okay, what are the complications of surgery? You have anesthetic risks, you have bleeding, of course, and you have prolonged air leaks. In cases of empyema thoracis, the biggest complication problem would be bleeding and prolonged air leaks. Bleeding usually should be managed by judicious use of going back into theatre for any if it bleeds, you just go back in and you clear the problem as it is. Prolonged air leaks are a bit more complicated. You might have to find the air leak, staple it off, or you might have to use maneuvers such as diathermy cauterization to sort them out. So your surgical results are quite good, 30 to 70% successful in stage 2 empyema. And usually with VATS, your symptoms disappear after 24 to 48 hours post-decortication, and you have a shorter hospital stay. Your mortality rates are quite low, which is about 9%. And our study is parallel with the Singapore study of 15% mortality for these patients. So as you can see, if you do a thoracotomy for these cases and leave a chest drain, the wound is quite big. If you do a VATS repair, the wound is quite small. But the saying is, the bigger the surgeon, the bigger the scar. It doesn't apply anymore already, I think now. So, all right. So in summary, acute empyema is easily treated. Focus on early chest tube drainage, early surgical referral. Chronic empyema carries a high morbidity and mortality, and it is an avoidable problem. Indications for surgery, take-home message for you guys, always remember, residual effusions on chest X-ray despite chest tube drainage you need. Surgery, non-re-expansion of the lung, multiple loculation, chronic empyema with trapped lung, and presence of complications would indicate surgery for these patients. So what are the other issues related to empyema thoracis? Bronchoscopy. Do you perform bronchoscopy for these patients? Dr. Amol, would you suggest bronchoscopy, you think?
Sir, according to BTS guidelines, they suggest bronchoscopy only when there is suspected airway
Yeah. So you would perform a bronchoscopy if you suspect there's a secondary lesion in these cases, causing the empyema thoracis. But generally, it is not needed. There is a condition known as pyothorax associated lymphoma. These patients presents with an empyema thoracis, and it is unique to B cell lymphoma. And uniquely and strangely enough, I have seen 2 of these patients. So, and somehow or other, they like to ask these questions during exams, especially this pyothorax associated lymphoma. So please go back and read a bit about it. Intrapleural fibrinolytics, spelling is a bit wrong. We discussed it before. There is no role at the moment. There is some textbooks that say that there is a role, especially the newer fibrinolytics, which is after the urokinase. But generally, steer clear from this, unless you are asked about a patient who is very unstable and a patient who cannot be subjected to surgery. Now, antibiotics and the regimes is a big discussion. I've asked Dr. Zamir to actually give me another session, if possible, to discuss this completely on its own. What about follow-up? These patients will be seen back normally after week 4 in our setting, and they'll be followed up at 6 months interval. And usually we will keep them in our practice for at least 5 years for quite some time. So the follow-up regime for these patients are quite long. The reason is because you, especially with patients with, if you settle them with VATS or with thoracotomy and drainage, there's no issues. But if these patients have got problems such as an open window and you need to do dressing regularly, then the follow-up has to be more frequent. That goes without saying. So I think I will end here, and I will take some questions, guys.
Sir, hello, sir, Amol here.
Yeah, hi, Amol.
Sir, the management of empyema is same in tubercular empyema and other pyogenic empyemas, or is there any difference between the 2?
There is a difference.
Yes.
Okay. Thank you, Amol. So basically, you have to be aware that the difference in this would be the introduction of your anti-tubercular drugs. And normally, these patients with Mycobacterium empyema thoracis, the empyema thoracis part will be straightforward, but when you do the procedure would be the one that is in contention. So I would say that if you have Hello. I lost you there, Amol. Hello.
Carry on. Your
Yeah.
questions are good.
Hello.
Right, Amol. So your question regarding Mycobacterium. So after usually when these patients present to you at an early stage, obviously the treatment will still follow the same management protocol that we discussed before: nutritional therapy, antibiotics, as well as thromboembolic prophylaxis. However, in the case of Mycobacterium, you have to be aware that these patients have anti-TB drugs, and you have to time the procedure well. Many a times, these patients present to you at 2 variable situations. One, where the empyema thoracis is already present and it is amenable to a chest tube drainage. Number 2, when there is empyema thoracis and the patient has got trapped lung, and in that case, you have to determine whether or not the timing is right for you to perform a decortication in these patients. If the patient is unstable, obviously you have to take the patient in and perform a decortication at an urgent time. However, our practice in Langkawi and Malaysia is always being to buy as much time as we can with these patients. As long as the anti-TB drugs can work, we will institute them. However, when there is an evidence of complication, when there normally is, we are quite aggressive about it. We do not wait much. So, to answer your question, the treatment regime is about the same. However, the timing in which you manage these patients would depend entirely on the patient's general condition itself. But if you suspect that there is an element of a trapped lung or empyema thoracis that requires a surgical intervention, then you should not delay it for any reason whatsoever in these cases. Okay?
Okay, sir. Okay. Sir, one more associated condition. If the TB cavity rupturing into the pleural space and causing empyema, how we manage the TB cavity?
Again, Amol, please ask me again. Sorry.
Sir, if empyema is secondary to rupture of the TB cavity, how we manage that cavity?
Yeah, so you can address it individually. You can address it individually, because usually the second cavity will not be that big. In these cases, usually you have got two distinct cavities, and there'll be one predominant and one not so predominant. And many of time when it comes to this stage, the patient is usually a bit unstable. So I would advise to please deal with the bigger cavity or the more complex issue first. And then subsequently, if you need to come in again a second time, come in a second time. But for patients with tuberculosis, the key is deal with the bigger problem first and run and save yourself quickly, because you don't want to get into trouble by managing a smaller cavity and then having difficulties with the patient. Okay? That's a very good question. Thank you.
Yes, sir. Thank you.
Dr. Andrea, anything that I can that?
So I have a question.
Sure.
So when do you do like a thoracic window for all these patients?
Right. So if these patients have got number one, we do, if you are able to get away with can you hear me? Sorry, hello.
Yes, sir.
Hello.
Yes, sir. I can hear you, sir.
Hello.
Hello, sir.
Hi, Dr. Mithun. Yeah. Okay.
Hi, sir.
Hi, Dr. Mithun. How are you? Hi.
Fine, sir. How are you, sir?
Great. So, Dr. Mithun, actually, for a thoracic window, if you are looking at a patient that is not stable enough to undergo a VATS decortication or a thoracotomy procedure, you can subject these patients to an open window procedure, number one. Secondly, if you find that there is a very well loculated swelling that is amenable to a window, you can actually choose a window as well. Window is getting more and more out of fashion now because of the improvement in technology involving VATS. So people now have modified, single port, uniportal VATS surgery, and that basically has taken over the role to some extent. The benefit of an open window is because you have got enough space after you resect the rib, and you are able to put in actually a good dressing for these patients, and the results are quite good, especially for patients that are not fit for surgery. So to answer your question, my main indication would be for patients that are not fit for GA, an open window would be good. Okay?
Yes, sir. So I have one more doubt, sir.
Sure.
So what is your, in your hospital, what's the management for loculated pleural effusion, sir?
We put in a non-loculated or loculated?
Loculated, sir.
We in our setting, first indication would be a guided chest tube drainage with a pigtail catheter first.
Okay, sir.
All right. And then
so not chest tube?
No, we put in a pigtail catheter first. And normally this will be managed by the respiratory physicians and the radiologist. And subsequently what happens is when they fail to drain enough, they refer it to us. So 9 out of 10 times we will be referred the patient usually. Okay?
Okay, sir.
Okay.
Thank you, sir.
Thank you. Any more question, guys? If not, I think, yeah. Sure, Amo.
Sir, 4 of us are appearing for refractive practicals.
Great.
February, sir. So,
Great.
So can you guide us on the kind of clinical cases which are common? What are the thoracic cases you get?
Sure, Amol. I tell you what, I'll give you my email. I think this would be better if I give you some information because it's quite a lot of things for me to cover. Okay?
Yes. Name them. Just to name them. What are they are like similar to India, sir?
Similar, very similar.
Yes, sir.
I believe the disease pattern is quite similar, I guess.
Yes, sir.
But I guess technology, in terms of technology, I mean, has has got more robots, and the laparoscopy is much
Yes,
better.
sir.
So
Yes, sir.
but I believe disease pattern and all is quite similar. So email me if you all would like some guidance on the FRCS. I'll be more than happy to help out, even
Sir. Yes, sir. Sir,
on
can we have?
non-thoracic. Yeah.
Yes, sir. Can I have your email ID, sir? Can I write it
Sure,
down?
I'll just type it out here so that you can
Yes.
see. It's yeah, it's all small letters. Okay, so you can just, I think if you guys want to have a session on Viva or any session, you can let me know, and I'll be more than happy to help out.
Excuse me, sir.
Yeah.
Can I have one more? Can I ask one more question, sir?
Sure, Mithun.
Sir, in this patient with empyema thoracis, usually on chronic cases there will be rib crowding.
Yeah.
So usually you told that you should place a 32 French chest tube for these patients.
Yeah.
So, but when the rib crowding, usually we can't place even 24 French chest tubes, sir. Like, how do you manage these kind of patients?
So Mithun, the newer consensus and also where we are going to now is smaller and smaller chest tubes. So 18 to 21 would be the choice at the moment now, but it must follow a guided principle. So if you have an ultrasound support, it should be a guided insertion. The tube must be flexible, and you must allow yourself the flexibility of increasing the size as needed later. And of course, you have to manage the tube by having regular flushing, 6 hourly, 50 cc's. And most of the time when you have rib crowding, you'll benefit if you have a suction device or a smart suction device such as the Medela. Okay?
Yes, sir. Sir, but one more question, sir. For these patients, if it's like small size test tube, it will not drain the collection. Like it's thick organized collection with the pus. So how will you drain this, sir? If it's not negative.
So that job would be taken over predominantly by the suction device. And Mithun, in these cases, if you are unable to drain after a few days, I think your option should be to open and have a look.
Okay, sir.
Yeah, because most likely, if you are unable to drain with a small chest tube, even if you put in a bigger tube, eventually it will get blocked, no matter what type of suction device you have. So in these cases, when you already know that the exudate, and I understand in India, the cases come with very thick and the space is very narrowed. And so I understand your doubt regarding this. So my advice would be, if you have these cases, have a very low threshold of actually converting them to surgery. Okay?
Okay, sir. Yes, sir.
Okay, that's a very good question. Thanks, man. Okay, guys, will that be all?
Just last question.
Hi.
Yes, sir. My question is that how can you easily connect a pigtail to a negative suction device? Because
It's very difficult. You have to modify it.
yeah.
So you have to modify it. So a pigtail device will only be used mainly for suctioning. But what I mentioned is, if you want to use a chest tube drainage with a small suction, if you want to use a small caliber chest tube, then an 18 to a 21 French test tube will be okay. But this is based on British Thoracic Society guidelines. However, in practical use, doctor, I still use big size chest tubes. However, I've adopted some aspects of the guidelines by now referring them to the radiologist for guided access.
So is there a role in flushing this?
Hello? Yeah?
Is there a role in flushing this chest tubes with saline or something?
Definitely. We use a routine 4 hourly 50 cc flushing to make sure that it doesn't get blocked in our practice. And the BTS guidelines also advocates this to some extent.
You just flush in saline or antibiotic?
No, only with saline. Just to keep it patent to some extent.
Okay, sir.
Okay, guys, I've got a call from the hospital. So maybe we can schedule this for some other time with the antibiotic regimes. And that's about it. Thank you very much for your attention.
Thank you, sir.
And thanks everybody for your kind attention. And let's meet again. All the best, guys. Take care. Bye. Okay. Hi, Dr. Zamir. Thank you, sir. And thank you so much for the.
Dr. Gafoor, thank you very much
Hi, Dr. Zamir.
for giving us the lecture. I'm
Thank you,
so
sir.
sorry that I'm scrubbed in theater, but
No, no worries.
appreciate your hard work, and we have recorded this and we will put it up
Yeah.
on the YouTube channel. I'll send a link to you.
That's fine, sir. If you require any more assistance, please let me know. More than happy to share
It was
my.
an absolutely fantastic lecture, and I really enjoyed it, I have to say. I just had to
Thank
go
you,
the last 10 minutes, so sorry about that.
No problem. Thank you, sir.
Well
Take
done.
care.
Thank you very much.
Thank you. Thank you. Bye-bye. Bye-bye.